Good. We see people dialing in. We start and welcome to the KYON webinar again. It's a series of webinars. This is now the 5th KYON webinar we do, and today we focus on total hip replacement. So first of all, thank you very much for your time and your interest. My name is Guy. I'm since beginning of 2019 the CEO of KYON. I would really like to say a great company with an amazing team behind. Our purpose, which we live every day, is to improve the quality of life for companion animals by equipping you with leading edge skills and tools. So leading edge tools refers to our commitment to make highest quality products, and leading edge skills to our strong focus on education so that you can achieve best outcome in your daily activities. Even during these challenging times we face today, in the last couple of months, we do our best to provide you the best learning experience. So now to THR. When Slobodan Tepic founded KYON in 1999, his first focus and product was the total hip replacement system, which he introduced to the market in 2002. Over the last 20 years, more than 20,000 dogs and cats, and including a tiger, by the way, by Aldo, have been treated with the Zurich Cementless hip replacement system. Until today, the system has gone through multiple iterations, aiming to improve the long-term performance of the device, and we are now at the 6th generation of Zurich Cementless total hip replacement system. So KYON has a long history and successful history with total hip replacement, and I'm excited to hear more about it from our speakers today, and who have really contributed heavily to today's total hip replacement system. So I'm grateful to announce Dr. Aldo Vezzoni from Cremona in Italy, then Steve Brezina, our Chief Technology Officer, who started working 33 years ago with Slobodan Tepic, and also on board we have Dr. Otto Lenz, professor at Virginia Tech in the US, who acts as well as Chief Medical Officer at KYON. Otto will manage and moderate your questions after the talk. The next slide, you can see quickly a very short introduction how you have to handle like questions. You can ask questions throughout the webinar. Feel free to do that. There's a tab called questions as shown on the screen, one for desktop and one for mobile. And please raise them there, and we will finalize at the end of the webinars, we will go into that. So let's get it started. I wish you a great learning experience, and I'm handing over to you, Steve, for the first talk.
Great, thank you, Guy. Pleasure to be here. Let's see how the sharing works.
Yeah, it does.
It does, great, okay. So as Guy said, this is the 6th generation of the Zurich Cementless THR. And this is the timeline of those changes. And it doesn't mean that, that we found that there was a bug with the system and then we made a change to it. When we started this, ultra high molecular weight polyethylene was state of the art. Everything that we had at the time was state of the art, but as the art changed, we've adopted and changed the system. So you can see now, the last few changes, we've added what's called a double shell on the cup. We have changed the polyethylene to PEEK and carbon fiber PEEK rings. We have HA coatings. We now have ceramic heads. So it's really the best that you can find in orthopedics that are being used in the KYON THR. Again, there's lots of cases that were done. As Guy said, there's over 20,000 total cases now by more than 280 surgeons. We are now at about between 1,200 and 1,400 procedures per year. And we now, with the Generation 6, really will probably find difficulty in determining what we're going to be able to do for Generation 7. So this is what Generation 6 looks like. The stems have this white coating on them. We have these series of necks with different offsets. The screws are special screws that lock the stem to the medial cortex, and the heads are pink. That's the trademark of the Ceramtex BioLux, which for veterinary use is called Verilux material. And then the cups have the kind of light brown PEEK with the black ring, carbon fiber PEEK ring on the inside. So there are three problems that we are defined that we need to solve for THR, and these have been from the beginning and still the same. So the stem needs to be attached to the bone, and it has to be strong enough. Same with the cup, attachment of the cup to the bone and strong enough. And then the largest problem that's been addressed by the industry over the last 10, 15 years is how to reduce production of wear materials between the head and the cup lining material. So problem one, how did we solve that? Well, we look at the stem bone attachment. You know, you have to fix the stem to the bone, and you have to do it so that it's immediate and indefinite. And this is, you know, okay, that can be done. Immediate fixation you can get with cement, but that's not going to be very indefinite because, as we know, in very active animals, that cement mantle breaks down fairly quickly, and you know, a year, 2 years later, how well those things are held in place is questionable. It fits the majority of canal shapes and sizes, you know, with a limited number of implants. I mean, we go from now with our mini THR system, we can go from about a 2 kilo size toy breed dog up to tiger size, 200 kilo tiger is the range of products that we can cover with, you know, about 10 different sizes of implants, which is pretty spectacular when you think that on some human press fit systems, there are 80 stems. So you have 20 stems to cover all the sizes. You have them with the collar and without a collar, that makes 40. And you have them in left and right. So that makes 80 different components to cover just for humans. So with 10 sizes, I think it's quite amazing that you can cover all of the breeds and sizes of animals that we can cover with the locking screw fixation, which is the technology how we get immediate and indefinite fixation. Now, it can also be used in young patients, since the fixation is really only to the medial cortex. As the femur were to continue to grow, the stem will just move along with it. It's not like a press fit system where as the femur grows, you would start to lose your press fit. And another thing that's very important to reduce stress shielding is that there's no coupling of the medial and lateral cortices, and you'll see how we achieve that with a gap on the lateral side. So the inspiration for the locking screw fixation of the stem for THR usage comes from the work that Dr. Tepik was doing back in the AO in the late 80s for locking screw fixed plates with the PC Fix project. So if you look at how this plate looks with the screws fixed to it, and then you move that plate to the inside of the femur, well, basically you have this. Have a plate with locking screws in it with a peg on top and that allows you to put a neck on there that transitions it to a cup. So this is how it looks if you just want to look at a rough sketch here. You have joint forces would come to the head on the stem. Those get transferred to the bone by shear, transferred across the screws. And then you have muscle forces on the greater trochanter. And because this is being fixed by screws that are serving as pegs now locked to the stem on the medial side, you don't need contact on the lateral side. You don't need to press the stem in there into some sort of a conical shaped form that's going to allow the stem to not subside when it finally goes down far enough. These stems are immediately stable. They're going to stay in that position where the screws are locking it to unless something doesn't go right, which seldom happens. The stem fixation is the easiest part of the KYON THR. And it's important that it stays stable immediately because you want to get bone on growth onto the stem as soon as possible, because bone on growth is what allows the load sharing to happen more. The transition is more gradual over the whole length of the stem and not just right at the top proximal portion. So the gap is important because if you put a stiff tube into a soft, or a stiff component into a soft shell, a soft tube, you'll end up having a much different load configuration on that outer tube, which is our femur. And by locking this only to the medial cortex, you decouple the medial and lateral cortices from the stem. So the stem is only sitting on the medial cortex, And the lateral cortex then still sees the same loadings as it would under normal anatomical conditions. So by this construct, there's very little stress shielding compared to, like if you look in human THR systems that are press fit, there's a lot of bone loss in the proximal part. And we don't see that at all with the KYON THR system. So as well, over the time, we have done things to improve the strength of the stems, because notoriously, as smaller or younger and younger patients get operated, the canal size at the time of the surgery is much smaller than what you could fit a appropriate size stem in for when the dog becomes an adult. So in the generation 4 stems, we changed to a shot peening procedure that then gives a good strain hardening to the outer surface. As well, we made it 0.2 of a millimeter wider. These changes gave us about approximately a 5% increase in the strength. Then in the generation 5 stems, we changed the production to forging first, and then shot peening afterwards, and then they're coated. And this gave us, again, an additional 5% increase in strength. You say, well, 10% increase in strength doesn't seem like very much. Well, it's probably not very much if you want to look on the vertical axis of this chart, and you're looking at just the increase in the load that it could stand under static test. We're more interested in the horizontal axis of this chart. So if you look at the point there, the case where you've got, we've got 10 million cycles over 7 years, we don't see hardly any failures that would be considered according to this loading. Where they start to fail sometimes is if you have, say, 50 cycles a year, 100 cycles a year of a loading that's much higher. So these are loadings like this. So if you had that 10% increase in the strength, well, if we had 350 cycles of this over 7 years, and now we increase the strength by 10%, look at how much we gain on the horizontal axis. On the horizontal axis, we gain almost 10 times the number of cycles. So here we only could take 350 cycles at that load, but now by getting 10% higher strength, we are out to 3,000 cycles, so almost a factor of 10 greater number of cycles at that load increment. So that's very important that we can gain that much strength with just these few things that give us 10% increase in strength. Another thing that is essential is that the bone on growth comes early. So this failure here, what has happened is that some years post-operative, the amount of polyethylene particles, and Dr. Vizzoni will talk about this, is the burden of these polyethylene particles causes bone to atrophy, and you start to lose the contact of the bone to the proximal part of the stem. So since the load sharing is not from the bone to the stem anymore, the distal end of the stem is the only part that's held, and this transition at the third screw hole, which is seeing all of the twisting loading, is where there's failure of the stem. So very important to keep the on growth onto the stem over the long period of time. And so to get that bone on growth on there quickly, we have gone to using a coating, and that coating is a HA coating. So HA coatings, have been shown in the human orthopedics that they really promote early on growth, and just by putting that on there, the bone really likes to adhere to that surface, and we see that is really helping. That there's not, very rarely do we see cases where there's loss of bone on the proximal part of the stem, unless there is this very high number of polyethylene particles. So the final stem that we now call the 6th generation of stem, it's the best alloy you can get. It's titanium, aluminum, niobium, which is the most biocompatible of the alloys. The manufacturing process with forging is typical for human orthopedics. Surface preparations are done to strain harden the surface to give it still extra strength. And then it has a pure titanium HA coating onto the surfaces that should be contacted by bone. So, second problem is the cup bone attachment. Well, we have an open shell structure, and in order to create this open shell structure, we've had to make our shells out of 2 components. Because the outer shell, we want to be very compliant to the bone, so not stiff. If you had a If you had a very thick shell with some holes in it, it would be much stiffer than the construct that we have. And it's HA coated for quick integration. So one of the most common failures in THR is loosening of the cup. Potentially that comes from an insufficient press fit at the operation time. But we want that bone can grow onto it and into it quickly. So the cups that we make are made of these double shells. So you can see here this outer shell has all of these holes. So these are the holes in the outer shell. And the amount of metal is very, very little. And that keeps it compliant, so that the stiffness of this titanium by the geometry with the holes helps to soften it so that it is more closely to the stiffness of the cancellous bone that it's mated against. In between it is a gap. Then there's a solid shell, which is the back support to the liner, which used to be polyethylene and now is PEEK. And you can see that when you have such an open structure like this, that the bone does grow nicely into those holes, and you get really good integration of these cups into the cancellous bone. And when you look at these 5 years down the line in x-rays, you hardly can tell that anything has even happened at that surface between the bone and the cup, as if it was just pressed in there the day before. So these are the cups. You know, they're double shell construction. They're this titanium alloy. Turning, milling, holes are cut appropriately. They're HA coated again. And now with the new liners, which I'll talk about now, with the PEEK, carbon fiber PEEK liner, we can address the wear part of the joint. So that was problem 3. Problem 3 is the aspherical bearing. So aspherical bearing is the way that we've addressed the wear by making a geometrical change to the coupling between the head and the liner. Now, our bearing material is ceramic on carbon fiber reinforced PEEK, which has been shown to provide one of the lowest wear couplings that's available. So we've made some changes here. Our generation 4 cups were ultra high molecular weight polyethylene with the fossa geometry. That's this aspherical bearing. Then generation 5 cups, we went to carbon fiber reinforced PEEK ring. And then with generation 6, we changed the heads to the Verilux manufactured by Ceramtech. So we've worked together with a company called KYON Orthopedics, which is Dr. Slobodan Tepik and myself, where we were trying to bring the Zurich cementless THR technology to the human orthopedic market. And you can see the human one here, it's just a little bit different. The screws are put in from the medial side instead of lateral, but very similar technologies. And with KYON, we had to develop a way to come up with wear reducing on the coupling between the head and the liner. But as a small company in the human orthopedics, we could not get involved with metal on metal. We didn't want ceramic on ceramic. And cross-linking polyethylene was not clear what the long-term results were going to be for that. So our solution was a geometric change. So this is what happens when you have a hard surface round pressing on a flat surface or one with a different radius. You get a high concentration of stress there. So these Hertzian contact stresses is what we wanted to try to avoid. And we did that by creating basically a dimple in the liner. So we've made in the liner where the contact is, we've made a recess there. And there's a special shape to the recess. Or you can flatten the head. And if you flatten the head, both of these things are changing the loading from being at the point, here at the pole, to basically a ring that is at 45 degrees around the circumference of the head. And by doing that, you see here, you put load there, you've got fluid in here. As you press the head into the liner, this amount of fluid is under pressure. It tries to escape, but it can't escape because it's being sealed at the ring of contact, which allows there to be a sustained fluid flow out, which means that the fossa, we call it, maintains the lubrication. So this should have some benefits, and we've done a whole series of testing on the hip simulators with these, and there is a good reduction compared to the standard geometry. Standard geometry of the same materials, the fossa, so the geometric change, gives you a 3 times reduction in wear. So recently we thought, well, how can we get away from polyethylene and use another technology we had, which was a ring for the contact point. And here what we've done is, you can see, we've put a ring here of carbon fiber reinforced PEEK inside of a PEEK liner, because data shows that carbon fiber reinforced PEEK, when mated with the ceramic head, gives us the lowest amount of wear. So if we started out here with what was kind of standard with a cobalt chrome head on standard poly, and then by changing to the fossa, so the aspherical bearing, we're down to this level of about 3.5 milligrams per million cycles. And then by making the change to ceramic and to carbon fiber reinforced PEEK, we expect to be down here in pretty much an immeasurable amount of wear. So we think this is going to have a significant effect on the long-term results, where typical failures up till now would be either the polyethylene liner wearing out or the amount of polyethylene debris causing the stems to loosen. And how is CFR PEEK? Well, there's enough studies that show that yes, it is a good material to use in the body. It's used in bearings, and the biologic response of CFR PEEK is very similar to that of ultra-high molecular weight polyethylene. And since there's such a large amount of fewer particles, we expect that to be even more significant, that there's much less response to the particles from CFR PEEK. So these are the heads that we use. These are made by Ceramtech. It's a company in Germany. They make approximately, well, they've had over 8 million implanted components of, this is a zirconia toughened alumina. Their trademark for human use is Biolux Delta, and for veterinary use, for KYON, it is called Verilux, and KYON has an exclusive license for this material in the veterinary industry. So we have these different combinations now. We have heads that are 16 and 19 millimeter diameter. The 16 is used with a 21 and 23 size cup, and the 19 with the 26, 29, and 32 size cup. So with our PEEK, CFR PEEK liners, we think we've really made the right step in moving away from ultra-high molecular weight polyethylene. The PEEK, carbon fiber reinforced PEEK materials are very compatible. We see the response to debris particles of this similar in the body to ultra-high molecular weight polyethylene. And it's the lowest wear combination possible with the ceramic heads. So in all of these steps that we've taken, we think that now with our 6th generation THR that we have probably the best system out there, and human patients would be happy to get such a high quality combination of materials. And with that, questions that you may have can be brought up in the Q&A session at the end of the presentations. Thank you.
Thank you, Steve, for the first presentation. And as Steve said, please raise the questions in the tab called questions, so you can raise that, type that in. We will follow up with them with Otto later on. We're now handing over to Aldo, Dr. Aldo Vezzoni, for the second presentation.
Okay, hello everybody. I don't know if this morning or evening here in Europe is evening, but in the United States is morning. So hello everybody. I'm very pleased to be here and to tell you what is my experience with this new system of KYON total rib replacement. And so I will also tell you what are my thoughts about this procedure after 3,000 cases I've done. Well, why so many? What is the main feature in this new system? So this is really a new system. It's very little to be connected with the previous one, because most critical points were already addressed and solved. And the main aim was to provide a lifelong lasting hip replacement for dogs of any size and cats too. So the concern of the owner when they accept to have their dog treated with a total hip replacement in a young age their concern is how long will last those prostheses, because they know that in people, after 15, maximum 20 years in young people, they need to replace the cup or something else. So that was the main point to be addressed. Then also the surgical technique has been tuned in the years to reduce complication, and we have been able to reduce complication under 3%, as I will show you. And another interesting point is the versatility of this system. So we can treat every condition requiring hip replacement, and also in case of complication, we can have successful revisions, keeping the prosthesis working. Another interesting point is about what's new today is the increased awareness of the indication and benefit of total hip replacement in dogs among people, among dog owners. And this is the testimony of many pet owners about the improved well-being of their dog after THR. So my dog is now smiling, from lazy to hyperactive, from sad to euphoric, from age to younger, and he's an happy dog now. So those are the best witness of the THR efficacy, and that is the reason why so many cases I had to deal with, because my clients were patient and effective counselor for other clients, because they were bringing their own experience, their own witness on the efficacy of the procedure. And so you can see a dog that is working, yes, it's working, but it looked like an old dog. It's just 6 years old. And the owner was quite worried about the weakness of that dog, not willing to go out, getting tired. And look, 1 year later, that is a completely different dog, because now he's an happy dog, because his hips are no more painful. So he feels comfortable, he wants to jump, he wants to run, and never tired. So the 6th generation of Zurich total hip replacement has brought 5 revolutions. Those are the main point I focus nowadays. So we have a permanent and quick osseointegration thanks to the HA coating. We have a peak cup liner to replace the polyethylene liner, and we saw the advantage of that. The ceramic head to reduce friction inside the joint, and then a dual mobility cup to reduce dislocation, particularly in big dogs, and the Cementless mini THR for small dogs and cats. Those are the 5 revolutions, and I will go through each of those points. About osseointegration, that is very important to have a primary fixation through the screws, and the screws are locking screws, so the stem is very strongly fixed inside the bone, and that will allow the dog to work immediately on a leash for security, but we don't need any cage confinement. That is one of the problems for the owner. They don't want to have their dog in a cage. And so we can avoid the cage confinement. It's just enough to keep the dog on a leash when he's outside, and is leave free in the house. About the secondary fixation by osseointegration, which is the permanent stability inside the bone, the advantage of the first revolution was to add the hydroxyapatite coating. That really speed up so much the integration, particularly if you put some blood clot before inserting the stem inside the bone. And then you can see here, it is a Bernese Mountain Dog, 3 years follow-up, a beautiful bone contact all over without any stress shielding. Another advantage was introduced last year for big dogs, 50 to 60 kilogram dogs, to have an extra large giant stem with a reinforced shoulders here, and so much stronger for those big dogs. But the cup liner with a peak to replace a polyethylene liner, that was the most important point to me, because our dogs have been treated with bilateral hip dysplasia, but look how much they move. So they have a much more activity compared to people, for instance. So that is the reason why with polyethylene we saw, particularly in young dogs, quite a very early wear of the polyethylene. Also, big dogs like this German Shepherd, for instance, So the stress on the implant is very strong because he likes to jump, to run and to stop and to run and to jump, playing with other dogs, making so much effort on the hips. Many owners like to go on vacation and they like to see the dog running, and again, a lot of stress on the implants. Even small dogs, they run like crazy because dogs they like to run. That is in their attitude to run, and because of pain-free joints, they run so much that they can cause wear in the cup if not protected with a better material compared to polyethylene. Also, we have dogs that do agility, and of course, they do training many times, and they do training every day, and then many times in the year they do racing also. So that means a lot of stress on the implants. Even small dogs like this, the Cocker Spaniel with bilateral hip replacement, he likes to run. Of course, the loading is less because of the body weight, but also the implants are smaller. So the activity, the wear can be quite dangerous for those small dogs too, if not with a good implant. So polyethylene was really a disaster. And that was particularly a big problem in young dogs. That being addressed, that technical problem is being addressed by implant improvement. So we moved from the original heads with a nitrate titanium to the amorphous diamond-like coating that was more smooth, and also the fossa. But nevertheless, there was a wear production, and the reaction was dependent by the biology of each patient. So in some dogs, we saw a huge granuloma formation inside the capsule and the joint space. And also that wear was quite soon. This was an Irish setter 5 years after total replacement. So the head was destroyed completely, the polyethylene going into contact with the metal and creating a lot of debris. And that debris caused also bone resorption along the stem. And that was one of the most common causes of failure and breakage of the stem because of bone resorption in the proximal part, and then twisting a micro motion of the proximal part of the stem until breakage because the distal part was still well integrated. And you see again a huge body reaction to that debris. But sometimes, like in this Labrador, you see that 2 months later after surgery, and there is a good bone contact of the stem, but even just 2.5 years later, you can see that we have a bone resorption along the proximal part of the stem, and moreover, we see much more at the 3.5 years. So at 3.5 years, if you look at the relationship between the prosthesis head and the cap, here is a coaxial, while if you go and see in the other view, sorry, I went too fast. If you see here, the head went completely inside the cap, and again you see a lot of bone resorption along the stem. This is a big stem, so it did not break, but anyway, there is some reaction here and could break later on. So the second revolution was really the PEEK cap and the carbon fiber reinforced PEEK inside where the loading is more concentrated. And again, to have a better and precise press fit for those caps, a special reamers to calibrate the preparation of the acetabulum has been prepared, also with a trial caps, so you can set and test if the press fit was good. This one is one of the oldest doc I did as far concerning the follow-up. So it's a 4-year follow-up, and there is no bone resorption all around the stem and all around the cap, and the head is well centered inside. So that was really the third revolution, and Steve already presented the advantage of where combining the PEEK with the ceramic head. The ceramic head came in production since October 2017. So the combination of ceramic head and PEEK was really a great advantage to really create a big revolution in cementless hip replacement. Yeah, I did already more than 700 cases implanted with ceramic head and PEEK, and the longest follow-up is 3 years, so no problem for so far. And this is a German Shepherd, 3 years later after hip replacement, and you see a very beautiful bone contact, no signs of bone resorption along the implants. Another problem was to reduce the dislocation risk in large breed dogs, particularly young dogs with luxoid hips like this Bernese, 7 months old, and you see that 2 weeks after the second hip it dislocated. And so that was the fourth revolution. The fourth revolution was to have this special dual mobility cup, which is quite common used in human people, because they can see the same problem. And so here we have a double articulation, and we have a cup with a nitrate inside, a titanium nitrate, and the head, that is the real dual mobility, is the head, because the head has a surface in PEEK that is articulated inside the cup, and inside the PEEK head we have a ceramic head. That ceramic head cannot come out because it's pre-assembled inside, it's retentive. So to dislocate that big head, we need to jump out all the big head. So the small head, the ceramic head, will pull out the big head, but you see that the jumping distance is so high, it's 25 millimeter the diameter, so it's very difficult to have such a dislocation. So really, we just presented the publication together with Autolans in over 100 cases, and we had only one dislocation, which occurred because of a deformation of the PEEK after trauma. So here is the first case we did. It was a Leonberger that 15 days later luxated. So we had to replace the neck with an extra long neck, which is not good because of the stress on the implants. But and the second hip, we moved with the first case of a dual mobility. You see here in surgery, which is inserted, and that dog was treated in that way. And we have a longer follow-up. This is 2 months of follow-up. The dog was working perfectly, no tendency to dislocation, and this is 1.5 years follow-up. Everything is stable. Taking advantage of that, of the PEEK, so liner, we don't need a bigger thickness. In that way, even for smaller dog, accepting the 26 cup, we can have a bigger head than a 19 millimeter head that is much more resistant to luxation or dislocation, and the range of motion is increased from 120 to 150 degrees. And this is an example in a flat coated with a quite lax joint being treated with this new cup. And again, the last revolution is the older series, the mini series, cementless for small dogs and cats. So ranging from dogs from 1 to 15 kilogram, because after 15 kilogram, most of the time the regular implants are suitable. And we have stem sizes ranging from 3 millimeter to 6 millimeter, with a 4 and 5 in between. And the cup size is from 10 millimeter to 12, 14, 16, 18, and 20. And the head size, 6 millimeter, head millimeter, 10 and 12. And we can use, we can combine interchangeable. So we can use, for instance, a stem 5 with a bigger cup, and then we can use a 16 millimeter head. So it's quite flexible. It's a little bit complicated, but it's very useful. So you can move from one different cup to a different stem and vice versa. Here is the example of the smaller 3 millimeter stem, which is a very small, very tiny, and that is suitable for dogs, 2-3 kilogram dogs. So we did a preliminary study in 13 cases for dogs ranging from 2 kilogram to 15 kilogram. And you see Jack Russell, Toy Poodle, cats, 2 Maine Coon, 1 British Maltese, Cocker, Border Collie, and Mongrel. And the most common system we used was a 4 millimeter stem, and about the cup, the 12 millimeter cup, and the 8 millimeter head, but also we use a different size of heads. Here are the smaller dogs, Rambo, a toy poodle, 5 years old, 2 kilogram, with consequences of necrosis of the femur head, and that is positioned in the table. So we look for fluoroscopy because it's quite critical to have a proper position of so small dogs on the table to rely on the anatomical landmark for the cup orientation. Also the stem preparation, very small, with a special reamer inside and a high-speed burr. And then calibration of the small preparation of the small acetabulum. And here you see the small cup that we are inserting. Of course, we use a very gentle hammering because very important to counteract the forces on the other side because they are so small, but then you can achieve a very good press fit. And then you can check with fluoroscopy the orientation of the cup. So small cups are completely produced in peak, so there is only a ring of metal and all the rest is a peak. The stem is fixed with a special jig, like the big jigs, but everything is smaller. So very tiny, very delicate procedure. And finally, you can reduce the ceramic head inside, test your stability, and then you can take your X-rays to evaluate the orientation of the cups. And this is a 2 months follow-up. That is regaining a good gait. About the cat, this was Oreste, a British cat with a slipped physical capitis of the right hip. You can see here. And again, position on the table as much stable as possible. And then again, we use in this case a number 4 stem. And again, we check in surgery, postoperatively, and this is a follow-up of 5 months of the cat that is working properly. So those animals are very good for keeping them quiet, but they need to be kept in a big cage. They cannot be left free in the apartment like dogs because it's more difficult to keep them under control. So my main comments after my preliminary experience with the Mini is more challenging than regular in performance. And so in doing that procedure, surgeon need to have a good experience with a regular THR before starting with the Mini, but it's feasible. And is an awesome possibility to perform a cementless THR in so small dogs and cats too, because up to now, only cemented prostheses were done in small dogs and cats. What we saw is a very quick recovery and very excellent satisfaction of the owner. This, for instance, a Maltese with a luxation on this plastic hip, so it was a 4-degree not weight-bearing lameness, and you can see here 2 months later how it's running like a crazy without feeling any pain. So that is a really fantastic outcome that can be achieved in so small dogs too. So this is really a totally new Zurich total hip replacement. And it's a complete system for any dogs from 1 to 100 kilograms because we can treat giant breed dogs too. In a regular or normal case, the incidence of complication can be reduced to less than 3%. That's what we achieved in the last 3 years. And also in complex and challenging cases, the incidence of complication is higher, of course, but can be kept under 10% and possibly reduced to 4 or 5% as it happens in 2018 in our cases. Nevertheless, the complex and challenging cases deserve total hip replacement, even there is a higher risk of complication. Looking at the cases in the last 66 years, from 2014 to 2019, you see that a very important drop of the complication and the explant too in the last years compared to the previous years. About challenging cases, I want to distinguish very clearly from normal cases of hip dysplasia in dogs from 7 months to 7 years, and challenging cases in more complex hip condition like luxoid dips in young dogs, giant breeds, chronic luxation, unsatisfactory FHO, TPO, DPO, arthroplasty, old dogs over 8 years with severe osteoarthritis and osteopenia, obese dogs, and non-union or malunion of femur head or acetabular fractures. So here an example of what we consider a normal hip dysplasia case where we don't expect to have a higher incidence of complication. And this is an example of challenging because of luxoid dips, so they have a high risk of luxation after surgery or very severe dorsal dislocation of the femur, so we have much more tendency to dislocate, or revision of FHO, we have a modification, we have a medialization of the trochanter, a lot of sclerosis of the proximal femur, as also in chronic capital fissure fracture, you can see in this case, those are really challenging to be performed. But also in old dogs, we have osteopenia, and you need to protect the femur for fractures. So looking at the complication in 2018 and 2019, with the 6th generation of Zurich hip replacement, accounting for 567 67 cases. We had 15 complications with an overall incidence of 2.6, no explant. But if you divide the normal cases and the challenging cases, and so the challenging cases is about 1/3 of the total, and the normal cases 2/3. And looking at the normal cases, we have only 5 complications, which means 1.4%, 2 fracture, 2 luxation, and 1 cup avulsion. While in challenging cases, we have a 4.8 incidence of complication, which is expected because those cases are more risky, and particularly luxation and cup dislodgement. The overall experience is fantastic because the dog regain the ability to gallop, which is completely lost when they are dysplastic. They do bunny hopping, but they don't do gallop, like you can see in this dog that is 6 and 8 months after bilateral hip replacement. So you regain the ability to gallop, which means a full function of the hip joint. Another important point for the Zurich total hip replacement is the versatility in challenging condition, as we saw in the cases. I want just show you a few cases like this obese dog, Diana, 48-kilogram Labrador, with dislocation, luxation of the hip on a dysplastic hip. So those cases are very risky, and we can manage them just protecting the femur in advance. So when we do our procedure, we bend an arch plate to follow the curvature of the femur to stay behind the stem, so we can fix the proximal screws and purchase in a good bone stock. And you see here how is the plate is bent, and that is a 4 years follow-up of this dog without any complication. And so the dog is still obese and now has a problem in the front legs, but the hips are sound. Also, other dogs with osteopenia and fragile bone, we always protect them systematically over 8 years of age with a chronic osteoarthritis. We do that procedure, and that make us much more comfortable to have no complication, no risk of fracture. Also, big dogs, San Bernard, 78 kilogram, we cannot use a regular implants, so we need the tiger implant, where designed for the tiger. And so we have a head which is 26 millimeter of diameter, so I have a very big jumping distance, and we did that in 7 cases, so we didn't see any luxation. This is Yogi, a Caucasian Shepherd, 68 kilogram, with a luxated this plastic hip. That is the dog, a big dog before surgery. So you see it's quite lame on the left side. And then we went with the tiger implants. And this is a 2 years follow-up of the left and just 3 months because we went to do the same procedure on the right side. And now the dog is okay. Failed FHO, failed DPO, other condition like in this golden retriever who had that procedure done as well, and it was not properly done, and they also the DPO did not work, and the other side was an FHO, and the dog was very, very handicapped in the gait and very painful. And so we went with a total hip replacement on the side of the FHO first, and then we went on the side of the DPO, and fortunately this dog has been able to follow. This is a 3-year follow-up with a good muscle mass and a complete regained function, and you can see that the dog is a completely another dog nowadays. Chronic capital fissure fracture can be quite challenging because we have an altered anatomy with medialization of greater trochanter, proximal femoral sclerosis, and difficult canalization, and also the acetabulum can lose a cortical bone, and so the press fit could be critical. So it is overwart, 5 months of age with a chronic capital fissure fracture that occurred 2 months earlier, and the dog was quite painful. And you see the shift of the body weight on the front limb and a very poor muscle mass. And so we went to do that is to do the procedure. And in those cases too, we need to protect the trochanter because it's quite risky to have a fracture of the trochanter during the procedure. And this is a 1-year follow-up, and the dog returned to normal gait. But the most challenging condition that we faced with the KYON, the Zurich total hip replacement, are the perisprothetic joint infection. That is the most devastating complication of total joint replacement, usually leading to explantation. Is still a challenge in the orthopedic community, human and veterinarian, and despite many efforts to reduce the periprosthetic joint infection, it remains at 1 to 2% incidence in people. So the first stage is explant, debridement, cytology, culture, histology, and then we can go for the second stage after 6 to 12 months with the bone remodeling, and in case of poor function, we can reimplant. We did that in 7 cases with a 2-stage revision, and this is one example. So we follow the development and the healing of the bone. You see that the periosteal reaction that is decreasing, and after 12 months you see a good smooth surface of the bone. We do a culture, needle aspiration into the joint, and then if it is negative, we can go and proceed with a reimplant. This golden retriever, Vanilla, was explanted in both hips. He got an hematogenous infection due to a severe gastroenteritis that went to affect both hips simultaneously. And so this is quite a long-term follow-up of both hips are reimplanted, and the dog is still alive and is doing great. Then I want to mention my unforgettable, awesome experience with the tiger in Leipzig in 2011. And that was a very milestone in our experience because that was the first tiger in the world with a cementless total hip replacement. Another tiger in Georgia was implanted with a cemented hip but did not survive. And what was interesting is that the implants that we use for that tiger has been used again in giant breed dogs like Bernese, Great Dane, and so on. So that is called the tiger implants for that reason. And this is a girl, name of the tiger, when it was left free to go outside from the big cage, and it was experiencing again the freedom to be outside the cage. The new challenge is in sport activity dogs. So we want to have those dogs to return to full sport activity when they were affected by hip problems, and we aim to regain high physical performance. This is an initiative sponsored by KYON, offering to 3 dogs that possibility for free. So they've been treated for free, implanted hip replacement in those dogs. And the reason was because they had a loss of performance. They were already in sport activity, but had a loss of performance because of hip problems. And so we want to check the wear of the cups, if any, after years, leaving those dogs to do again a complete physical activity. This was the first dog we did, Michigan, a border collie, and the right side was affected by osteoarthritis, the left side was sound. This is a 2 months follow-up, and you can see that the dog is returning to training. And now is still in training. Is a very generous and very dedicated dogs for that activity. So we really want, we wish that he will regain a full function. This dog has it was taken away from agility and was put under to do agility underwater, which is another type of activity that those dogs do, because it was getting too tired doing regular agility. So we went and did bilateral hip replacement in this dog, and now is still already in training again. And we can see here that is starting with small jumps, but just a few months after the second tip is regaining a good attitude for this sport. So in conclusion of my personal experience, yes?
Thank you. Go ahead. We are running out of time, just to let you know.
Oh yes, mine is finished. That is the conclusion. So very positive experience, a really new hip replacement system. Most critical point was addressed and to find the solution. Long-term survival of the implant is really expected nowadays, and also a significant reduction of complication from the 12% in the past to the 2.5% nowadays. So more confidence to address severe hip condition in young dogs for lifelong benefit of and full function after hip replacement. And Cementless is available for any dogs from 1 kilogram to 100 kilogram. These are, you see, implants for 2 kilogram dog and 100 kilogram dog. You see the huge difference in the size of the implants and the stem. What I learned after 3000, motivation is the engine that moved me forward. Constancy and perseverance allow me to improve the surgical performance, and I will focus on repetition and repetition to do it better and to get consistent outcome. And that it was aiming to reduce complications, studying all the risk factors. Anytime we saw a complication, we wanted to understand why that occurred. And also it's very important to develop a good empathy with the dog owners to meet their expectation and also to solve problems when occurred. Consistent repetition is like to play musical instruments, aiming to perfect performance, because as soon more time you repeat, the more time you get better. Or like a stem, you want to have like an assembly line to do always in the best way in a very consistent method. I did the presentation in 2011 in Chicago, and that was the title, My Last 1,000 Cases. So I told it's not an end result, a starting point to apply the gained experience to improve the technical and future development, and to share the experience done with the scientific community and to let other surgeons take advantage of our pioneering experience. So nowadays, I would say exactly the same. And so my goal is really to discuss with other colleagues, to teach other colleagues to take advantage of my experience. And a sincere acknowledgement to Slobodan, to Steve, to KYON staff, particularly to Guy, to my family, and to all my staff. And thank you for the attention. I will be pleased to reply to your questions. Thank you.
Thank you, Aldo, very much for this impressive
Aldo,
presentation.
thanks.
Well, this achievement you have done in the last couple of years. So let's jump directly. We will add another 15 minutes, just that everybody's aware, another 15 minutes for questions and answers. So please stay in the line if you are interested for the questions, and I hand over to you, Otto, to manage and handle this discussion. Thank you, Otto.
Okay, thanks. I have a few questions, but just before I get started, I'd like to congratulate Aldo again for 3,000 cases. That's monumental, and to thank you for all your help, at least with me, and helping me getting a better understanding of the total hip. That's much appreciated. The first question goes to Steve. A quick question regarding if you have the 5th generation total hips, can you interchange them with the new ceramic heads? What's your feeling on that? In particular, going back to the 5th generation and 4th generation with high molecular weight polyethylene cups and ceramic heads.
Well, you certainly can mix them. I mean, you're gonna be probably better off because you've got ceramic now running against the polyethylene, but there still is the risk of polyethylene wear. But you know, if you don't have the latest version of the cups and you're comfortable still putting in the old polyethylene ones and they have not expired, that's going to be a key point, is what the expiration date was on the sterilization of the liners. You know, that piece of plastic has been sitting in a bag now for 5 years, so it's essentially a 5-year-old product. It would just be better really to change up to get a new cup. But the ceramic can certainly run on it, and the geometries are correct, so you wouldn't have any, you know, risk or disadvantage of a wrong size head running inside the cup or something like that. So it'd be okay.
Okay. Next couple questions are for Aldo. One of the most popular questions is, when do you decide to use the dual mobility cups? Is it just for Luxoid hips only, or for revisions, or when do you recommend using them?
So now we have quite a confidence with that dual mobility cup, which is available only for 29 and 32 cup, 32 millimeter cup. So you cannot, it's not available for the 26. But for the 26, we have the 19 millimeter head, so that is quite more resistant compared to the 16 millimeter head as was in the previous version. So I use that mainly in Luxoid hips and in big dogs with a long leg, because even they are not Luxoid, they have a higher incidence of luxation. So I still use the 29 or the 32 regular cup with a 19 millimeter head in older dogs with a less range of motion, but most of the time I prefer to go with the dual mobility cup, which make me more comfortable.
Okay. And the next question is concerning the use of the C-arm or intraoperative fluoroscopy. How necessary do you think that is to use? And if you do not have the use of the C-arm, is there any other recommendations you can give to evaluate the position of the acetabular cup intraoperatively?
No, unfortunately, there is no other way. And the reason why I'm still using, every time I do a THR, I still use the CR, even I have the experience of 3,000 cases, because you can never predict exactly if the pelvis moved when you do the procedure, when you do the reaming of the femur, the reaming of the acetabulum. So if you want to be sure, and you want to be sure that when you take your X-ray postoperatively, you don't have a surprise, the cup is too open or too close, and you need to go back in surgery. And going back in surgery is always a risk of infection. So to me, is really mandatory. When I teach in my courses, I always tell that is fundamental. I start using the C-arm 20 years ago. I bought already several C-arm, mostly used from human medicine. Now I have a new one because I'm making many cases I could invest better. But really, you can find quite cheap fluoroscopy unit, and they are very, very, very important. I could not do without nowadays.
Okay. And the next question is, it seems the incidence of performing bilateral total hip arthroplasties is increasing. Do you feel that there are more cases that need bilateral total hip replacements overall?
Oh, yes, I always recommend bilateral hip replacement. I don't like to have a dog that has one bad hip and one total hip replacement, because it will overload the hip prosthesis, because the dog feel pain on the other hip, and probably the owner will not really recognize that lameness, because the dog with four limbs is able to mask the pain in that hip. But if you look at the muscle mass, you see that the muscle mass in the hip replacement is double than the other limb. That means that prosthesis will be overloaded. And I think that to have to reduce the wear, to have a long longevity of the implants, you need to share the loading among the two hips. So that is a problem of benefit of the dog and well-being. So you remove one source of pain of arthritis, and then you preserve the hip that you already implanted. So when we tell the owner the dog has a problem on the other hip, you should do the second hip in maximum 1 year. Otherwise, they lose the guarantee. You know that I offer a full life guarantee for any problems to the implants, but if they don't do the second hip, they lose the guarantee.
Okay, and the next question that we have is, and this has been asked a couple of times, what's your feeling on performing DPO and TPO? Are you still performing a lot of those, given that you can perform total hips now in younger and younger patients? What's your preference?
My preference is I don't do TPO since 20 years, or 15 years, sorry. Since 2006, when it's been presented in ESVAT Congress in Munich. So I do DPO because I feel that is much better, is better and preservation of the anatomy of the pelvis compared to TPO. Nevertheless, we do DPO. We did one today also, and it's my preference when the indication is really there. And it's very likely that the indication is lost very quickly. So my preference for dogs about 5, maximum 6 months of age. After that age, most probably the indication is lost because you already some synovitis. For instance, if the dog is lame, so has a very clear clinical signs, it means that it's a synovitis. And synovitis means that you have already erosion of the cartilage, and that is a contraindication for DPO. So DPO is a preventive surgery. It should be done when you see an excessive joint laxity in a puppy without already signs of synovitis. So my preference for that, because I can preserve the hip joint, and I have already 600 cases of DPO done. And it's beautiful to see those dogs for all their life with their own joints instead of artificial joints. But if you do DPO when the dog is already advancing in the generation of the joint, then they will deserve total hip replacement later on, which is not good to have 2 surgeries for that patient.
Whoops. Okay, one other question, and this one is another question that was asked a few times. What is the best way to estimate the size neck that you will be using after implanting the acetabular component? Most people do know about using the round ball and the drill guide as a spacer, but do you have any other information or advice that will help estimate the length of the neck?
I think there is a proportion on the size of the dog. So if you do a Bernese Mountain Dog, for instance, or Newfoundland, of course you aim to have a medium neck and not a short one. If you do a Labrador or a Border Collie or a Golden Retriever, most of the time they are fitting well with a short neck. And if you do even giant breed, of course you can go to long neck, which is more proportional. So to set that, we always check the clearance between the bar inside the cup and the cut on the neck, on the femur, and then we want to have 1.5 centimeter of that distance, pulling the leg distally to be sure that at least the short neck will fit. Because the mess, the problem is that if you don't have that 1.5 centimeters, so you will not be able to even put a short neck. And then if you use an X short neck, most probably you will be punished in few years because the range of motion is more limited, and the X short neck can impinge with the cap, creating debris. So the X short should be very, very much limited in use, and most cases of dogs about from 20 to 35 kilograms, they are good for a short neck, and going over, you will go from the medium. I very rarely use the long neck, very rarely, only for revision when we have a luxation. But my preference is to use a short or a medium, depending by the size of the dog.
Okay, and the next quick question is, how young is too young for a total hip?
The youngest dog we did was a 4.5 months, and we were obliged to do because he had the luxation since already 1 month. But of course, that is not the best age. We had a lot of dogs that we did at 6 months of age, particularly when they have a full luxation, because if you wait, the luxation will create a dorsal dislocation of the femur that will be very tricky to reduce with increased risk of further dislocation of the prosthesis. And so we prefer to go directly with a hip replacement even at 6 months of age. If I can choose, because the condition is not so severe, I think that the best age is between 8 and 9 months of age in younger dogs.
And the next question, I guess we'll go to Steve, concerning HA coating on the implants. What is the difference between the trial femoral stem and the actual femoral stem that's coated with HA, or is there a difference? I think you're muted, Steve.
It's 0.2 of a millimeter larger, the actual implant versus the trial implant. And
Okay.
It's also a rougher surface. So if you're having trouble getting that trial implant in there, it's going to be a good indication you're going to have a lot of trouble getting the real implant in there. Not only the 0.2 of a millimeter, but the rough surface.
Okay. And this, probably the last question will go to Aldo concerning sclerotic bone. When you have a lot of sclerosis of the acetabulum, do you see any difference in bone integration of the acetabular component? And is there anything that you do specifically in these cases to help with bone integration?
When you have a sclerosis, the sclerosis is an issue in the femur. So for preparation of the femoral canal, and when you have that sclerosis that you can anticipate looking at the X-ray, you have to use the high-speed burr to help you to go inside and not to perforate the caudal cortex or the lateral cortex. So it's very important to have a high-speed burr available. Concerning the cap, nowadays I don't use anymore the revision cap. And the reason is because the peak cap are stronger, more stiff, and so you can achieve a very good press fit even if you have a cancellation of the acetabulum because it was not loaded, because it was after FHO, for instance. So you can get a very good press fit with the new peak cap. And since already 3 or 4 years, I didn't use anymore any revision cap.
And just to follow up on that question, because I did respond to the person that asked it, are you still recommending the osteostasis and the bone graft from the proximal femur in the acetabulum once you've finished your reaming?
Yes, every time we see cortical bone, we do osteostasis, and in the fossa, if some remaining fossa is there, we put some cancellous bone that we collect when we ream the femur.
Okay, and I see Guy appearing, so I think that's all the time we have, and I'll let Guy wrap things up.
Thank you very much, Otto. And yeah, first of all, I would like to take the opportunity to thank you, Dr. Aldo Vezzoni, for your presentation, but also for the achievement of the 3,000 cases. So well done, Aldo. Steve as well, thank you for joining for your presentation, and Otto as well for moderating the questions. And I would like also take the opportunity to thank all attendees for taking part of this webinar, but also our team to make that happen, that we're able to do these kind of things and this kind of learning experience. And we hope we met your expectations. Just like a few final words here, what you can see on the slide, as soon as the webinar closes, there will be a very short survey, just like 5 questions, and we would appreciate to get your feedback. Second point, we will continue to provide education courses for THR as listed on the screen, and some much more courses about PGR, POL2, and so on. So further information, please visit our website on KYON.ch. And if you're also interested to get further information on education, webinars, events, new products, please subscribe to our newsletter. That's also available on the website. And finally, you will receive a follow-up email after that webinar with the recorded session, so you can review and go into the presentations again. And if you have any further questions, we are here to help you, and please contact us. So I wish you a great afternoon or evening, wherever you are. Thank you again for joining, and have a good one. Bye-bye.
All right.
Bye-bye.